The next section, we're gonna free discussion about several things. The editorial office informed me that Professor Columbus are interested in the screening of hepatocellular carcinoma in China. Is that true? So if you,
No, actually, no. My question was more focused on the today topics was CCA. As you know, it presents late because we are devoid of any screening program. And in fact, my question to a colleague of ours was how often they see this cancer developing on the top of primary sclerosing cholangitis. I am perfectly aware of the story of the flukes, which is a kind of an epidemic in the Southeast Asia and in other regions of China, of course. So I wanted just to explore what the colleagues of mine are doing in terms of screening, which patients they do screen, and if they use the endoscopic ultrasound guided fine needle aspiration for improving staging of extrahepatic cholangiocarcinoma in the preoperative selection of their patients. That's it.
Oh, okay, great. So, you know, in the Southeast Asia and in the very south part of China, you know, the cholangiocarcinoma CCA is not relatively higher because of the parasite infection, you know, the flux infections, because they eat of the raw seafood, the kind of not seafood, this is raw fish, the freshwater fish, and the freshwater fish was contaminated by the human feces sometime, and this is a major problem. In the past decades, the things like that, and now I think especially in the Thailand, and also the Guangdong province in China, probably this kind of public health issues already be treated. People are not suggested to eat stuff like this, even how much delicious it is. To stop eating the food like this, so the incidence of the disease step down. But the major cause of this disease, that is I think the obesity, and also something concerned about is the metabolism syndromes like diabetes, mellitus, and also the other things increase the inflammation levels, systemic inflammation levels, probably increase the incidence of this cholangiocarcinoma in this specific group of population. You know, other the CCA is much rarer compared with this hepatocellular carcinoma in China. So we focus on the early screening of the HCC because this is the leading cause of death about the liver disease. So, actually the cholangiocarcinoma was not set up for the screening officially because of the lower prevalence, the low incidence of this disease in this population, as compared with the hepatocellular carcinoma. So probably some surgeons here might know something about this, how to do some kind of use some specific device for the early detection of that kind of disease. From my point of view, or from the article submitted to our journal, I don't believe we have the very mature one for the screening of the earliest CCA in China or even in the southern part of Asia. I don't think so. We don't have that kind of issues. Just people go to the hospital and find, okay, they got a jaundice, okay, and then physical examination, sure, it is a very advanced CCA or gallbladder cancer, and different from this hepatocellular carcinoma. That is, I think this is kind of problem. How your opinion about the Professor Shi or Professor Yang? Do you have any kind of idea about this?
Okay. In fact, I recently do some research for the genotype DNA sequencing, and from our research for the anti-origin, and the first reason is hepatitis B infection, and the second is the cholangitis, and also about cholangitis is about 20 to 30%, and Frank's is only about less than 5%, and also some patients with fat liver and such as NASH about 20%. So the first reason is also in the ICC patients. I just talk about the ICC patients, the intrahepatic cholangiocarcinoma, not CCA, not a cholangiocarcinoma, is intrahepatic cholangiocarcinoma. Is just the first reason in China is hepatitis B infection, about the 40 to 50%, and also
Okay,
the second,
okay.
yeah.
Okay, I just like the HPV is can directly induce the ICC or through the inflammation.
Just in our research, is we just reviewed. I just in the East Hospital, Hepatomegaly Hospital is also have recently a research is their ICC patients is about the 50% is for the HB infection.
Right, sure. Maybe more than 50%. Maybe more than 50%. But I don't believe the HBV is the etiological agent of ICC because of probably cause the chronic inflammation, and this inflammation eventually lead to the malignant transformation in the the bile duct cell, epithelial cells. Is that true?
In fact, I'm very interested in this. So just we just start just retrospective for this patient. We found this percent just yeah. So also we find some.
Yeah. Can I make a comment, doctor? You know, just referring to the association between chronic hepatitis B and intrahepatic, mass-forming intrahepatic cholangiocarcinoma.
Yes.
It was originally pointed out by a number of studies coming from Korea, as you know, and America. Dr. Choi at Mayo showed that chronic hepatitis B increases by several folds the risk of developing mass-forming intrahepatic cholangio, and that the reason why we are seeing more intrahepatic cholangio is because we screen our patients with chronic hepatitis B with ultrasound every 6 months. But there is an important and critical point regarding this, that for 20 years or so, at least in Europe, we have been used to make a diagnosis of a hepatocellular carcinoma in patients with cirrhosis, including those with advanced hepatitis B, by utilizing the radiological criteria or wash-in followed by wash-out. When we critically reviewed our patients that have been resected for an intrahepatic cholangiocarcinoma, and I say we in Milano, but it has been also already done in Korea and in 2 other hospitals in China, it was clearly demonstrated that 15% of mass-forming nodules in chronic hepatitis B having wash-in and wash-out were indeed intrahepatic cholangiocarcinoma. So definitely in Europe, we have been missing a number of intrahepatic cholangiocarcinoma based on the fact that we were not used to perform liver biopsy when a patient showed up with wash-in, wash-out features at MRI or CT scan. So the real question is that this happens also in alcoholic liver disease and also more worrisome in NAFLD-related liver diseases. So I predict that mass-forming intrahepatic cholangiocarcinoma is becoming more and more popular, is gaining popularity as a diagnosis if we put enough attention to patients having wash in, wash out, and perhaps performing more liver biopsies prior to select patients to surgery. Unfortunately, we have done a lot of radiofrequency ablations in patients without liver biopsy, and we missed the opportunity to detect cholangiocarcinoma that, as you know, have a completely different treatment strategy and prognosis with respect to early hepatocellular carcinoma. Okay, thank you for this.
Okay, okay. So then we're gonna free discuss about this this panel. So we probably like to, my point of view about this, the cholangio issues, that is, any factors that can increase the inflammation levels in the liver might contribute to development of the cholangiocarcinoma. Are you agree with me? Professor Si, are you agree with me about this? How about the Professor Han? What's your opinion about this? Yes, go ahead.
Yes, Pascal, it's very interesting question. So, as mentioned, and as Professor Colombo mentioned, it is very interesting that intrahepatic cholangiocarcinoma, especially mass-forming cholangiocarcinoma, has a similar characteristic of hepatocellular carcinoma, and as Professor Colombo already mentioned, that it is associated with chronic B infection. So, Professor Kao asked me about the chronic inflammation and the association of chronic inflammation and the cholangiocarcinoma cancer. So I think it may be the factor. So, as you know, the chronic hepatitis B is the factor for hepatocellular carcinoma, but it's very well-known factor. But as Professor Colombo already have mentioned, that I think it may be the hepatitis B chronic virus infection may be the factor for cholangiocarcinoma as well. So Professor Kaoje asking about the association of inflammation and cholangiocarcinoma, especially in hepatitis B, may be the factor.
Thank you. Thank you for the, prove this kind of hypothesis. But, as the question about the professor.
Yeah.
Yes,
Can I put another question to the distinguished panel of Asian colleagues? I tell you frankly, here in Europe, we are stressed by the argument, the ongoing argument about primary sclerosing cholangitis and CCA, mainly proximal and distal. The issue is that if you read the American books, if you talk to a colleague of ours in the northern country of Europe, including UK, they will tell you that after 2 years after the diagnosis of primary sclerosing cholangitis is done, you should start monitoring your patients for the risk of CCA. I tell you 100% sure that it is not the case in Italy. We have been extensively reviewing the association between diagnosis of PSC and CCA, and it does not exist at all in Italy. We do have patients with primary sclerosing, but primary sclerosing here appears to be a milder disease with respect to what we see in the northern country. Now, I take the point that genetic matters. The PSC that we are used to see in Northern European countries and America as a follow-up of the Pilgrims migration comes from the Vikings. There is a kind of a Viking gene that drives the risk of primary sclerosing. And at the same time, it drives the risk of cholangio, which is not operating at all in our milieu, in the Mediterranean milieu. We see a number of patients with this mild performing primary sclerosing cholangitis, mostly intrahepatic, never ending up with cancer, and rarely progressing to biliary cirrhosis. But again, if you perform a liver biopsy, you see the onion-like structures around the bile ducts that clearly make the diagnosis of primary sclerosis cholangitis trustable. So my question to you, dear friends, you are genetically different from us. Your ethics must be completely different from ours. So what is the evolution of primary sclerosing cholangitis in your places? How often primary sclerosing cholangitis ends up with cholangiocarcinoma? Thank you.
Right. This is a very, very nice questions. I found the Professor Sun Feng is just appeared and then they disappear again. Okay, no problem. So, the cholangiocarcinoma, chronic cholangiocarcinoma is here in the Eastern populations, not 100% genetic predisposition, something. Probably the mostly happens is by the environmental contributions, especially for the infection. So Professor Sun Feng is here, right? Can you hear me? Professor Colombo gave you a kind of questions, tries to answer this question. So what is the difference? Something happens, cholangiocarcinoma here in the Eastern populations might be different from the Western population. So what is the major cause of this cholangiocarcinoma in the Eastern populations? Something concerned about the cholangiocarcinoma probably caused by the parasite infection or some kind of inflammation caused by the virus infection, whatever. So what's your opinion about this? So how to got the early diagnosis of the cholangiocarcinoma? So this is, I think, I need your information about this.
Yeah, that is a very difficult question because depending on the location of the CCA, some patients may have objective jaundice. It can early diagnosis, but in other patients, because he is the liver tumor, he had no any virus appearance on imaging study or even in clinical symptoms. So these patients difficulty to be diagnosed earlier. And in the etiology of CCA in China, hepatitis may be the major risk factors of this disease. And the biostones may relevant to the large population of patients in China, particularly in the southeast area of China. So I think the different etiology of ICCA might be associated with the different treatment options for this disease, particularly in ICC. For some patients with ICC with background of hepatitis B, the antiviral treatments and some treatments like used in the HCC may be preferred method in our clinical practice. Otherwise, for some patients with the background of biostome, the malignance of tumor was aggressive, and this disease is difficult to be treated. And the patients always have a poor prognosis after surgery or even after other treatment options. So I think the etiology may relate to, on the other hand, etiology may be related to some gene mutations.
How we perform in the clinical.
My real question, Professor Cao, was how to optimize pre-operative staging. I read the article from Mayo that's very intriguingly presents data that support the use of endoscopy, ultrasound guided fine needle aspiration of malignant, unsuspected malignant lymph nodes, which apparently double the rates of malignant lymph nodes being detected in the preoperative staging of cholangiocarcinoma, as compared to the traditional MRI, CT scan, and of course, FDC PET. So my question goes also to Professor Cascino, of course, but also to all the colleagues of our surgeons who are struggling in optimizing the pre-operative staging of their patient with CAA. The question is, do they use endoscopic ultrasound assisted fine needle aspiration of suspected lymphocytes in pre-operative staging of CCA? Thank you.
Okay, and I think the Professor Yang and Professor Shi, can you address this the specific? Can you point out something about this? This is the the angiographies for the early diagnosis. Just Professor Colombo point out something concerned about this. Do you got the point of this question? Professor Yang, do you got the point?
In fact, we used in our clinical practice is just a screen early diagnosis for the CCA. Is this a question?
Yeah, sure. That is because about something until some kind of apparatus try to monitor the disease or doing the biopsies. Probably any other options for the early diagnosis of CCA.
No, my real diagnosis is a little bit further on. It deals with the staging of lymph nodes.
Okay, staging for the
okay. Whether they rely on MRI, CT scan, and PET, or do they use also endoscopic ultrasound guided fine needle aspiration of the lymph nodes? Because I perfectly understand that sampling the tumor burden is associated with an enormous risk of seeding and should be avoided from a surgical standpoint. My question is about lymph nodes for staging and improve selection. Thank you.
Professor Kao?
Yes. Yes,
may
go
I
ahead.
May I answer the Professor Colombo's question? So actually, Professor Colombo asked about using endoscopic guided fine needle aspiration. So yes, so even in our institution, we sometimes use endoscopy fine needle aspiration for the pancreas cancer for diagnosis. But for staging, I think to do fine needle aspiration is not good. As Professor Colombo mentioned late, I think it may cause spread of the tumor cell. So I think for the lymph node status, I think CT or MRI, even if we are expecting the metastasis, we can do PET. So it's enough. So for fine needle aspiration for the lymph node, maybe too much, and also it may cause spread to peritoneal metastasis. So this is my opinion.
That's great. That's great.
Thank you so much, Doctor. Your point is a very important one, because if you read the paper on hepatology by Balinkowski at the Mayo Clinic, they claim 0 seeding following fine needle aspiration of lymph nodes. And this was my concern, because I am doubtful that this is true. You are right. I think that also, as far as lymph nodes are concerned, the risk of seeding is there. Thank you.
And one addition, Professor Colombo, another addition is that if there's some previous fine needle aspiration or fine needle biopsy, operation sometimes may be difficult because of adhesion or inflammation or leakage. The operation may be difficult, and it may also adversely affect the survivor. So, as you mentioned, I don't like the fine needle aspiration for the staging. Thank you very much for your excellent question.
And so, Wenbin, what's your problem? Well, what's your questions?
Hello, Professor. I am an investigator of mechanisms, so I was more interested about the connection between carcinogenesis mechanisms and the clinical application. As Professor Colombo pointed out in his article in the hepatoma research, he said that the PD-1 inhibitor is good for the patients with the mutation about the mismatch repair. So which means the PD-1 repair is more useful for the patients with mutations. And as we recently just finished in study about the mutagenic genes and the risk of cholangiocarcinoma. Interestingly, we found that the genetic polymorphisms of mutagenic genes, they have different effect on the risk on the gallbladder cancer and the cholangiocarcinoma. We know the cholangiocarcinoma and the gallbladder cancer, they all come from the biliary epithelial cells. Their anatomy location is close. They share the similar microenvironment, and the function is similar. However, for the same SNP point, which is a single nuclear polymorphism genotypes, if the same genotype, they may increase the risk of cholangiocarcinoma. However, they will decrease the risk of gallbladder cancer. That means the development of these two cancer are quite different. My question is, if there is a similar difference in the outcomes of target therapy on the cholangiocarcinoma and the gallbladder cancer, since if they have the difference in the developing in the carcinogenesis, they will have the different outcomes when the patients receive the same targeting therapy strategy. Maybe I can get the answers from the Professor Stefano or Professor Colombo.
Thank you.
Well, I can only make a general comment on this. If we look to the hepatocellular carcinoma, where a number of molecular pathways have been explored, and none of them in the end found to be of strategic importance in developing of a targeted therapy so far, because of the, as you know better than I do, the story of addiction. So I'm not very familiar with what the colleague of ours said. I hope that Professor Cascino can provide a better answer to his question. Stefano?
No, thanks, Massimo. No, I think that is really a very nice question, because this point may be relevant even for the design of clinical trials, probably because the biology of these tumors are potentially different. And generally, if you look at, I agree that probably immune checkpoint inhibitors may be potentially useful in patients with mismatch or repair deficiency tumor, much more than all. And you can overcome this potential resistance by combining them with the lenvatinib, for instance, because probably you can modify the microenvironment. But I think that probably we have to consider that if you analyze the mutational landscape of this tumor, we find something different in intrahepatic cholangiocarcinoma, in gallbladder, and extrahepatic. And probably we need to design clinical trials some different, and to enroll patients in, for instance, if you have an IDH1 or 2 mutation, probably I think that you have to enroll only patients with intrahepatic cholangiocarcinoma. Otherwise, you have the risk to treat patients with gallbladder gallbladder or extrahepatic carcinoma, and whether these mutations really are rare. So it's very, very unlikely to observe a response in these tumors. On the contrary, if you have a BRAF mutation in gallbladder cancer, you can find it. So I think that may be useful to test gallbladder cancer for this mutation, because you can design a trials, for instance. I think that probably we needed to design a basket trial, an umbrella trial. We have to identify in these different tumors, different mutation, by knowing that probably the incidence of this mutation are different according to the site of the tumors, intrahepatic, extrahepatic, and gallbladder. So I think that we require a strict collaboration with the molecular pathologist in order to, and the pharmacologist, of course, in order to identify this mutation. Or if you look at, for instance, FGF receptor 2 fusions, if you look at the incidence, is really low, even for intrahepatic cholangiocarcinoma, but more or less are zero for extrahepatic or gallbladder. So far, I think it's useless to test or to use this drug or to test even for this mutation in gallbladder. But if you have BRAF, you have MSI, you have, for instance, L2, or for instance, a GFR, probably I would like to test in gallbladder, because they are not so frequent, but they may open a new rooms for the treatment of this patient. So I think that we have to consider different sites, different mutation, and we have to analyze according to different site the specific mutation. We discussed with Professor Colombo now the Epstein-Barr virus, the presence of Epstein-Barr virus in these tumors. We are really surprised that in Asian population this is not so common, and we would like to test even if this happen in patient, in Italian patient in reality. And this is another message from you to us, that we don't consider until now, General. We have not considered better until now these tumor markers, and now we are to test if they are present, because in this case probably immunotherapy may play a role for the treatment of them. So I think that we have to change our mind about and our attitude to assess tumor's mutation and to treat this patient according to the tumor mutation, not to test each kind of patient, but specifically mutation for specific site of tumors.
That's great. That's great. Thank you. Thank you, Professor Cassino and the Professor Colombo for the nice interpretation. Okay. Okay, great. So I consider about something. I think Professor Shen Feng have the publication in the Journal of Clinical Oncology. Says about the staging of the cholangiocarcinoma. Is that true? So you're talking about the staging things clinically, either including the the lymph node or any other things can be used for the staging of the cholangiocarcinoma. Professor Shen Feng.
Yeah. Hello everyone. I'm the student of the Professor Shen Feng, and my boss is on the travel to another meeting. So this question from the Professor Tom, it's my turn to answer this question. Because this work is mainly worked by me. So at that time there is a 7-stage systems for the intrahepatic cholangiocarcinoma. However, the most common used stage system is the seventh TAMC stage system, which proposed by the Nathan and the Pavlik, who now is the director of the surgery department of the Ohio University. And that stage system can only divide the patients into the subgroup. So our stage system is based on the scoring. Is scoring of every patient. This stage system is a specified the nomogram, which include 7 variables, and the 7 variables which is the serum tumor marker, 2 serum tumor markers, which is the CA and the CA99, and 5 another pathological variables, which is lymph node metastasis and the direct invasion to the peritoneal, and the tumor size, the tumor number, and invasion to the vascular, to the major vascular, and these seven variables was included in this staging system. So by this staging system, we can calculate each patient's the corresponding score, and with this score we can conclude the possible progresses, such as 5-year post-operative overall survival probability, and so which is not only the stage system, it is also with this tool we can also calculate the possible progresses. Okay, and so we can choose the appropriate patients for the surgical treatment.
All right. So, Professor Crumble, how are you satisfied with this? The addressing things from Dr. Li Jun, the first author of this paper, of the JCO paper, I guess, right? And the paper describes about the earlier stagings of cholangiocarcinoma. Uses a group of the clinical lymph node or maybe the serological markers to realize this staging purpose for the cholangiocarcinoma.
Sorry, Professor Tom. Our stage system is not merely for the early ICC. It is for the all resected ICC. So these ICC patients were included from the early years, just from the 2007 and 2007 and the 2012. So as everyone know, some surgeons may choose the patients for the surgery is according to the guidelines, or according their technology, or according their some patients may, from the international guidelines, it's not inappropriate for the surgery. So our staging system is not only for the earlier ICCs, but also included some advanced ICCs, which may be not for the surgery from the options now.
Okay. So how about this? Do you have any further issues to need to discuss about this, Professor Colum?
No, I'm very satisfied. I learned a lot from you and Professor Cascino, so I have invested my time at the best. I'm so happy being with you. And I take the opportunity to wish you all the best for the incoming holy season. And I think that whenever possible, to have more of these interactive Zooms with these super experts in Far East, we need to exchange more of our thoughts, frankly, to make medicine improving in terms of delivering guidelines and recommendations. Otherwise, if we stick in our own geographical domain, we will have less and less opportunities to learn. At least this is my point. And I thank you very much for giving me such a very nice opportunity, Professor Cao. Thank you.
Professor, you are very, very calm, very, very calm. And I do appreciate your contribute your important article to my journal. So this is a very, very exciting things. And I think that we're gonna distribute this article to all our colleagues, let them to know how about the proceedings. And what we set out this kind of discussion, try to accumulate the message from all these experts around the world, try to make sure what kind of regimes, therapeutic regimes should be very, very useful for the treatment of our patients and our clients, and to improve our therapeutic efficacies for the kind of deadly malignant disease. So any more questions try to discuss? I think the Professor Shi, you have some more things to address.
Chairman Cao, I have last questions. Just I ask Casino. Yeah, patients with cholangiocarcinoma has really high rate of the tumor recurrence after resection. Neoadjuvant therapy has become an important strategy to improve overall survival and decrease tumor recurrence. Could you comment the possibility the schedule in the treatment of cholangiocarcinoma as neoadjuvant therapy?
Thank you for your question. I think that is a crucial point. I think that probably the result of neoadjuvant therapy with chemotherapy plus lenvatinib and immunotherapy could change, but you are right. Until now, probably the question is, can we have an effective systemic treatment to be used after a radical resection? And unfortunately, I think that we use commonly capecitabine because according to the Big Cap trial, but I know that probably is not so strong the results. And we have to pursue new way in order to select the patient. So far, I think that the question of to define the staging of the patient with positive lymph nodes before surgery may be an option to treat this patient with a preoperative treatment. Once again, I am not able to answer which kind of chemotherapy could be the best for this patient. So I think that we use capecitabine as adjuvant treatment when there is intrahepatic CCA. And sometimes when we have gallbladder or extrahepatic CCA, we use chemoradiation therapy because I think that the possibility to have a local relapse is very high. And in some cases, a small number of cases, of course, we use a combination of gemcitabine and oxaliplatin. I know that this is not well demonstrated any effectiveness for this treatment, but sometimes, at least in my mind and my colleagues in Italy, there is the feeling that they are not adjuvant treatment, but probably this is a treatment for an advanced disease that we are not able to demonstrate, but there is not a localized, but is really is a more advanced stage of disease. So I think there is, I'm not able, in reality, to answer this your important question, because we generally select the treatment according to after a discussion with the surgeon, with the pathologist, and so far we have not a clearly standard of care. For each patient, we can decide something different according to these variables. I don't know if you agree this. I know this is not a scientific view, but sometimes it is a medical feeling. I know that this is not should be used currently for all the patients, but sometimes we follow this way.
Okay, that's great.
Thank you. Thank you.
Thank you.
Thank
So
you.